Molecular testing, allergy diagnosis, application in daily clinical practice. Okay. These are my conflict of interest. And the first two questions are why and how to use molecular diagnosis in daily clinical practice. Starting with the first question, the answer is quite simple. Because when you have a given sensitization, for example, to peanuts, you have to know if such sensitization without any clinical relevance, such is the case of CCD sensitization, or you are in the presence of hyperreactivity to labile molecules with slight clinical symptoms, such is the case of profilin or PR10 sensitization, or if you are in a very more dangerous world, like those represented by lipid transfer protein sensitization or seed storage protein hypersensitivity, like to S-albumin or cupin, disylin, legumin. You can also find patients having very rare conditions like oleosin or defensin. And you should bear in mind that you should also consider the possibility that your patient could have at the same time more molecule sensitization, resulting in total different possible clinical pictures, like I'm going to show you in the following slides. And how to use molecular diagnosis. Okay, I do not have any general rule. I can just share my experience. In our institute, from 2013 to 2019, we could visit more than 40,000 people. And in those patients, we could use the molecular approach, multiplex approach, in about 15% of cases, more than 6,000 people. Like a simple example of the combined U-shaped approach, where you are going to use the deductive approach in more complicated cases, whilst you can use classical approach, classical diagnostic workup in all the other cases. But what about the predictive value of Ig molecular sensitization profile? Okay, in order to talk to you about the clinical profile of sensitization associated with the distinct and different picture of a molecular recognition, I'm going to show you, ladies and gentlemen, my data in a quite different way using the radar chart. The radar chart is also known as a spider chart. This is a graphical approach that you can use to visualize at the same time more observation with a two-dimensional chart, where several quantitative variables can be shown at the same time on axis, starting from the same point. Every single spoke represents one of the molecules studied, and the length of the spoke is proportional to the odds ratio that I placed on the y-axis. And the odds ratio is relative to the association among that molecule and the clinical symptom studied. And as you know very well, when you have a value and the odds ratio value above 1, you are in the presence of a positive association. And such association could be more or less strong, from weak to very strong. On the other hand, when you have a value below 1, you are in the presence of a negative association. Therefore, the molecules will follow within the central circle. And in this case, you can consider that specific molecule as a protective factor. But talking about some examples, some model regarding such activities, such radar graph, starting with food-dependent exercise induced anaphylaxis. As you know very well, when we consider a panallergen sensitization, the omega-5 gliadin sensitization is associated with DEA occurrence, but in southern Europe, especially in Italy, we could demonstrate about 10 years ago, that more than 80% of patients are reactive to lipid transfer protein in the case of DEA. On the other hand, when you have a simple oral allergy syndrome, you can find the presence at the same time of multiple sensitization to lipid transfer protein, profilin, and PR10. On the other hand, when you have a severe reaction to food, once again, you can find the presence of lipid transfer protein, but in the absence of profilin and PR10, that is, you can see here, falls within the central circle. Therefore, our protective value in consideration of the possibility to develop a severe reaction to food. And taken together, lipid transfer protein could not discriminate any condition and in condition related to food allergy, but the presence of absence of other molecules such as profilin or PR10 could be extremely important to define the outcome of your patient. And as you know, in Southern Europe, especially in Italy, shrimp allergy represented the second major cause of severe reaction to food. And in fact, tropomyosin and sarcoplasmic calcium binding were significantly associated with the occurrence of severe reaction to food. You know that lipid transfer proteins are relevant allergen in Southern Europe, but in this study we could compare the situation observed also in England, and as you can see, the profile of a recognition of the distinct molecules belonging to lipid transfer protein are quite similar, comparing Italy and England, even in the presence of my sources of sensitization totally different. But talking about respiratory symptoms, as you can see, when we consider the rhinitis and the genuine marker of sensitization, the most relevant and common species-specific components of environmental, both indoor and outdoor allergen are represented. And the same can be said also in the case of bronchial asthma, where lipocalin resulted to be selectively related with the presence of bronchial asthma. And talking about panallergen, once again, we could find the presence of several panallergens that are positively associated, like polcalcin, profilin, and PR10, and other panallergens like lipid transfer protein and tropomycins that are negatively associated. And interestingly, such situation is absolutely the opposite to what observed in the case of severe food allergy, where lipid transfer protein and tropomycins are positively associated, and PR10 and profilin are negatively associated, and this makes sense. And talking about panallergen and bronchial asthma, as you can see, once again, we have polcalcin and cyroalbumin that are selectively related to bronchial asthma. Therefore, taken together, as you can see in this resuming picture, there are specific pictures that are associated with all the different clinical status when you consider species-specific components of panallergen. And the interesting thing is that such picture can be also replicated at individual levels, therefore depicting a sort of allergogram where you can describe the situation of sensitization for each patient at the same time. At this point, just few words regarding atopic dermatitis, which is a real interesting condition that comprises several distinct patterns from a pathogenetic point of view of diseases. And we focused our attention on patients having a Th2 phenotype. In those patients, we could find that beta-1,3-glucanase olein-9 from olein-3 sensitization and superoxide dismutase F6 from Aspergillus fumigatus reactivity were strictly associated with atopic dermatitis, therefore can be considered as a sort of signature of atopic dermatitis in the Mediterranean area. In fact, such molecules were recognized in about 1/3 of patients, value far above to what observed in the atopic contrast. But another interesting clue is the fact that the vast majority of patients having Th phenotypes and atopic dermatitis could recognize an incredible number of molecules at the same time. In some cases, more than 80 molecules in the same patient. And the recognition was specific, always devoted to the same panallergen, as you can see. For example, there are panallergens that are absent from such evolution, from such recognition, such as a lipid transfer protein or profilin. But despite such high ability to recognize very dangerous molecules, severe respiratory symptoms of food allergy occurrence in patients with atopic dermatitis was always significantly lower when compared to atopic contrast, as you can see in the slide, both comparing the overall population and the single age groups. But taking together all those considerations, all those information, we can try to depict several tentative diagnostic algorithms. And starting with respiratory allergy, the first model we are going to consider is ausdasmite allergy. And you know that in about 80% of cases, patients with ausdasmite reactivity can recognize DERP1 and DERP2. In these cases, in this wonderful paper published by the group of Susan Vitala and Rudy Valenta, the authors could demonstrate that only in these cases patients synthesize a measurable amount of IgG to DRP1 or DRP2, and it can be achieved the presence of a reduction of IgE synthesis to DRP2. In all the other cases, this does not happen. And therefore, evaluating DRP1 and DRP2 reactivity in patients without asthma is an added value to enhance the success of the immunotherapy. DRP23. Paolo Matricardi could already demonstrate that DRP23 is associated with the onset of asthma since the school age. We could confirm such observation in this multi-center study where the vast majority of patients with asthma were also DRP23 reactors. Therefore, this is another important clue for clinicians. You have to check such reactivity in order to better follow your patient. And what about DRP10? Okay, you know, because I've already told you, the DRP10 is a tropomyosin, therefore is associated with food allergy, but is a protective factor for the respiratory symptoms. Therefore, DRP10 identifies patients having food allergy and not a respiratory allergy. And moving on to another model, the pollen allergen model. Okay, you know that in Southern Europe, especially in Italy, we have a very complicated situation, and the diagnosis of pollen allergy is quite a challenge because you have to verify, first of all, genuine molecule sensitization, and at the same time, check the possible presence of an allergen recognition, because all those complex evaluation could affect the outcome of your patient. For example, if you have a patient having a genuine sensitization to pellitorin and grasses in the presence of profilin recognition, okay, you are going to have a patient having worse rhinitis symptom in about 0.5% of cases in oral allergy syndrome. On the other hand, when you have absolutely the same situation, but in the presence of polcarsin or serum albumin and lipocalin recognition, okay, you could have an augmented risk to develop asthma. Therefore, you have to follow up your patient more carefully. And please be careful when you have a plant tree, olive tree, or mugwort reactivity. Such reactivity could be the result of a lipid transfer protein recognition, therefore disclosing a total different picture. Let me the chance to move on to this another topic, the food allergies. Starting with lipid transfer protein reactivity, we have already demonstrated that when you have a patient having a wider ability to recognize more lipid transfer protein at the same time, as an indirect proof of his capability to recognize the entire length, the entire structure of lipid transfer protein, and at the same time, the ability to recognize only lipid transfer protein and not other panallergens. As already shown you, we are in the field of the orange line. You have a lipid transfer protein reactivity without PR10 and profilin recognition, okay? This subset of patients show the higher risk to develop systemic reaction to food. And on the other hand, when you have a scant ability to recognize lipid transfer protein recognition, and at the same time, the sensitization to, at the same time, lipid transfer protein, PR10, profilin, okay, you could have a lower risk to develop systemic reaction to food, but be careful because in the presence of several important factors that you know very well, exercise after food ingestion or painkiller intake or alcohol consumption, okay, you are in the field in these cases of high risk to develop systemic reaction to food. Therefore, profilin and PR10 reactivity, labile molecules that are totally destroyed after cooking, are quite a safe sensitization. And in fact, when we focused our attention in the past in patients having lipid transfer protein reactivity and seed storage protein sensitization, the subset of patients also reactive to profilin showed a significant lower risk, significant lower occurrence of systemic reaction to food in both cases. And you know very well that when you have a patient with PR10 reactivity, in about 70% of cases, you can have an oral allergy syndrome. But Quite recently, me, Riccardo Zero, and Giorgio Celli could collect a series of case reports demonstrating that in the presence of several other cofactors, for example, the ingestion of high amount of food, of the liquid state of the food, of the status of fasting, of the intake of antacid, of specific pathological conditions such as atrophic gastritis, okay? In those cases, you can have a severe reaction to food, even in the presence of so-called harmless sensitization, such as profilin and PR10 reactivity. Therefore, in the vast majority of cases, profilin and PR10 sensitization are associated with low risk to develop systemic reaction to food, but also in this case, please be careful, because also in this case, you can have the possibility to develop a severe reaction to food in the presence of specific cofactor. And this is my last slide. I'd like to thank you for the attention from Italy, and please stay safe and healthy. Bye-bye.